Changing behavior around healthcare issues is a complex and multifaceted effort. We know that carrots work better than sticks, but even if those carrots work, our current tools and survey methods for measuring behavior changes aren't really as accurate as we'd like them to be. So how can we solve that problem? And what would that mean for patients and plans? We'll find out on this episode of ShiftShapers.
Change either energizes or paralyzes. The choice is yours. This is the ShiftShapers podcast, bringing the employee benefits industry interviews with individuals and companies who are shaping the industry's shifts. And now, here's your host, David Saltzman.
And joining us to help answer that question is Ross Bjella, founder and CEO at Alithias. Hey, Ross, welcome.
Hey, David. Thank you.
Thanks for joining us. I appreciate it.
Yeah, it's my pleasure.
So let's talk a little bit. We always like to find out, kind of how you got to be doing what you ended up doing. What was your journey?
Wow, the patient journey for me and the entrepreneur journey started when I was the CEO of another company, kind of being forced to help my employees find high-value healthcare. And on many occasions, I would walk into the office and there'd be somebody waiting to see me because their child got hurt in the football game or fell off their bike or had to go to the ER or had to have an MRI. And they knew it was going to be expensive, but didn't know how their benefit plan worked. And the HR person either didn't communicate with them or just they didn't understand. And since they saw me all the time, they just said, hey, well, we'll ask you. And so I ended up helping a few of them and really found out how difficult it is to find out what things cost, where to go for these services, why there's no quality information around. And it just became very, very frustrating for me. So when I left that company, I thought, there's a business here. And 14 years later, here we are, working with over 100,000 employee lives and 200 companies across the United States.
And still working at it and finding out, the recipe. I think somebody on the podcast a few years ago we were talking about allegedly consumer-directed healthcare. And they used a great phrase that I think you must work on a bunch on the back end. They said that we've essentially created a bunch of functionally uninsured human beings. We've got folks who've got, insurance cards in their wallet, but who've got ginormous deductibles and out-of-pocket responsibilities, and they don't know how to use their plans wisely. So is that recipe something that you guys are working on? Is that kind of part of what you guys do?
Yeah, absolutely. But what you said was 100% true. These people who make $30,000, $50,000 a year and have on average less than $600 in their savings account are functionally uninsured. And they're just hoping that something bad doesn't happen. And that was really my eye-opening experience coming at it from a senior executive position where if I have a $2,000 health expense, it's a bad day. But for most of my employees, that's a financially devastating event. And that's when you really look into their eyes and think, wow, did the decision I made about increasing their deductible make sense? Because it benefited the company. And, we're thinking, I'm going to increase the deductible from $1,500 to $2,000. Or I'm going to put a penalty on for going to the ER to $500 or something, and not realizing at all that you just sunk a quarter of your employees who couldn't afford it for the first time.
Well, and maybe more to the point, the secondary piece of that is that you've also sunk your healthcare plan, because what these folks tend to do is they defer care until they are so sick that they have no choice. They show up in an ER, and something that started as a cough and could have been treated for a couple of bucks ends up being an 8-day stay in ICU for $70,000, $80,000, $90,000.
Yeah.
So nobody wins. It's just a question of, it's like Uwe Reinhardt when he was at Princeton used to talk about hydraulic medical economics, and he reckoned it to a tube full of liquid, and he said, if you push down on this side, the liquid's going up on this side, and if you push down on the other side, the opposite reaction happens, but the liquid is still the same amount of liquid in the tube. It's just got to go someplace. So I know one of the things that you all have worked on diligently is you're really heavily invested in data and using data that in a way that becomes actionable. Can you talk a little bit about how that works both for the individual and at the plan level?
Yeah, let's talk about the data that's available to the average person. So, and this is really important for all those broker consultants out there who are developing consumer-directed health plans or community health plans, or they have a health plan that encourages consumerism and they're trying to use some of the data that's available or under the CARES Act, the data that is now being published by some of the hospitals. So that's the first part of it. So the real data, the most accurate data is adjudicated claims data. If you can get that, then you can see what things actually cost within a network. Unfortunately, a lot of networks don't provide that information, or the companies haven't invested in structuring the data so you can really see all the different claim line items that go into a rather complex procedure. Now, a colonoscopy, typically if it's a screening colonoscopy, you've got two claim line items for a screening, 45378 for the facility and 45378 for the physician. That's simple. But even when you get into a little bit more complex colonoscopy with a polyp removal and maybe cauterization or maybe a tattoo that someone might put in the colon to show where they removed a polyp, now you've got lab and pathology that goes along. And most people, and anesthesia, it's not uncommon to have that. So people who are trying to find, well, what is the cost of this, unless they're really understanding what goes into each procedure, just going to those files that are now published through the CARES Act, it's really hard to find the correct answer because the average person doesn't know that in a colonoscopy I could have Versed, which is twilight anesthesia, or I could have attended anesthesia. Well, Versed's $35. Attended anesthesia is typically $300 to $1,500. And you don't know which your provider is going to use. So how do you look at this and look at these data points that are being published and know what's real and what's not real, or know what should be included? So a friend of mine, Leo Wisniewski, has got Health Cost Labs, and Leo has published a lot of this data, and he's got an app called Billy, and it does do a pretty good job of showing what these costs are that are being, or the prices that are being published by the health systems. And I refer to that from time to time, and I'm on a regular basis talking to Leo about, does this data look right? Is this incorrect? And the truth is there's a lot of junk data out there, and you really have to know what you're looking at to know if something's good or not. And so when I see a hospital facility fee that's being published as $600, I know that that's not a good number. Someone messed up on the data file, But the average person isn't going to know that, and the typical broker consultant who's just looking at this may not know that as well. And I think you really have to be careful about who you use to provide the information.
Well, on the pre-adjudicated side, radiologists, anesthesiologists, pathologists, oftentimes not part of the network. So a patient thinks they're going to a network facility and they find out early on in the first set of billing that, oh my gosh, those guys are charging the sky's the limit because, well, they're not in network, and that creates confusion and et cetera, et cetera. So once you get that data, and let's assume that you're able to get clean data that's actionable, how do you present that to a mere mortal, a non-geek like us, in a way that's actionable for themselves and their family?
You have to normalize the data so that you have the same inputs. You're comparing apples to apples. So for me, when I'm looking at colonoscopy providers, for example, I don't need to know whether they're using attended anesthesia or Versed, or what goes into their sauce as to how to bill for the procedure. Because you see a lot of goofy things. Like I see hospitals sometimes adding these 99999 codes for transportation of materials, and it adds $150 onto the claim. It's ridiculous. And for colonoscopies, oftentimes you see them throw on a E&M code for seeing the patient, which is atypical, but you see it happen all the time. And then we see in certain facilities where the percentage of the patients that have a polyp are so far beyond the normal distribution in a population, you have a question about that. So you really have to understand kind of what's going on with that particular location. And I can tell you that if someone goes in there for a screening colonoscopy in that particular scenario, it's going to be coded as a colonoscopy with a polyp removal, and I'm going to assume that somehow that group is getting every patient that requires a polyp removal in the state. But it doesn't matter. So if I've got two people and they're turning right out of their driveway, if they go to that location, it's going to be billed in a certain manner, and it's going to cost that much. But if I can get them to turn left and go to one of the higher value places that I know do clean coding and that I know are decent quality, we've won the game. And that price difference is probably 50% of what the other group would be. And that's not atypical in healthcare.
So how do you connect the patient with the data, with the carrot? And what are the carrots? How do you get them motivated to go to the place that gives you clean data, where you know you can depend on getting a true reflection of what the procedures that were actually done?
Yeah, the best broker consultants out there have figured out that money works, and even the simplest person can understand that in certain cases, if they go to this provider, there will be no cost to them. And that's the magic word, no cost to you or free. And so these tiered health plans that are becoming much more popular, it's a win for everyone. It's a win for the providers who are offering this high value, trying to fight it out against the big health systems that advertise on TV at night, where your independent GI doc or orthopedic doc, they don't have that big money that the teaching institution has. Mm-hmm. So they're going to win because you're going to send them patients. And those patients are going to pay a fair amount of money. And I'm not even talking about negotiating anything down or going outside of the network or anything like that. And these broker consultants who know the game know that these independents exist. And if they can get the patient to go there, they've set up a plan design that waives the deductible and coinsurance when you use these high value providers, whether it's imaging, orthopedics, colonoscopies, just many, many different procedure types.
And now, a word from our sponsor. You're not just an advisor, you're a game changer. Forget cookie cutter off-the-shelf solutions. That's yesterday's news. It's 2025, and it's all about delivering bold, custom-crafted plans that truly make a difference. At the core is a razor-sharp self-insured framework, but the real magic? That's in the high-impact point solutions you strategically layer in to slash costs and supercharge member outcomes. But let's be real, that's where the headaches start. Hours wasted sifting through endless options, wrestling with integration issues, and fighting data sharing roadblocks. It's a time suck, and it's holding you back. Not anymore. Meet BenePower, the AI-powered game changer that builds killer plans in minutes, not hours. BenePower doesn't just curate the best point solutions, it makes them work together seamlessly, streamlining communication and driving collaboration like never before. With BenePower, you're armed with an end-to-end AI-enabled solution that makes you unstoppable. Spend less time piecing together a patchwork plan and more time selling. Your clients get unmatched ROI, and you become the go-to advisor that everyone's talking about. Want to take your game to the next level? Visit BenePower.ai or schedule a demo at info@benepower.com. Find your power with BenePower. And now, back to our conversation. And now, a word from our sponsor. You're not just an advisor, you're a game changer. Forget cookie cutter off-the-shelf solutions. That's yesterday's news. It's 2025, and it's all about delivering bold, custom-crafted plans that truly make a difference. At the core is a razor-sharp self-insured framework, but the real magic? That's in the high-impact point solutions you strategically layer in to slash costs and supercharge member outcomes. But let's be real, that's where the headaches start. Hours wasted sifting through endless options, wrestling with integration issues, and fighting data sharing roadblocks. It's a time suck, and it's holding you back. Not anymore. Meet BenePower, the AI-powered game changer that builds killer plans in minutes, not hours. BenePower doesn't just curate the best point solutions, it makes them work together seamlessly, streamlining communication and driving collaboration like never before. With BenePower, you're armed with an end-to-end AI-enabled solution that makes you unstoppable. Spend less time piecing together a patchwork plan and more time selling. Your clients get unmatched ROI, and you become the go-to advisor that everyone's talking about. Want to take your game to the next level? Visit BenePower.ai or schedule a demo at info@benepower.com. Find your power with BenePower. And now, back to our conversation. So, those best agents also know that the longest period of time in the universe is the period of time between the open enrollment meeting when you discuss this stuff and the time somebody needs care and has forgotten about this stuff. Do you create an advocate that, okay, well, if you're going to have this, you should call these people and they can explain to you where to go and why? Or how do you deliver that information so that it really is, to use the phrase off of your website, it's a carrot, not a stick?
Yeah, and that seems to work. There's all sorts of company cultures that we've experienced over the last 14 years. And some company cultures will do exactly what they're told to do. It's the culture of the organization. Other cultures, are the opposite of that. And you really have to cut through that to understand, how do we communicate with these groups? And the one time you communicate them at open enrollment is never going to be enough.
Right.
So how do you create an environment which facilitates recognition of those people who are saving money or who are making informed healthcare decisions? And so we do a lot of things by promoting the benefit plan, promoting the contact of an advocate. And so on many of these plan designs that we have, we encourage our employer clients to offer something that's common and probably may not have a big price disparity within it. I'll just give you a mammogram, for example. For a 3D mammogram, I think a high value place is $220 in our markets. Typically, it could go as high as $350 for a decent value place. They can get crazily priced, $850. But compared to a knee replacement where you're going to save, $20,000 at a procedure, a mammogram you're going to save $200 or $300 maybe. But if you can put an incentive there, or you can waive the cost, the women who make 80% of the healthcare decisions in the United States are going to say, wait a minute, I got this for free, or since mammograms are typically a covered event, I got a $25 or $50 cash incentive, and if my child or my husband needs a procedure, they can get a cash incentive too. And all I need to do is look at this list of procedures or providers that are free or that offer an incentive. Then that seems to remind them to think about it and make the call.
As you work with advisors, do you have materials where you educate them to say, here's one of the best ways to get through to folks, here's how you make this known throughout the course of the year? I mean, what do you do on the education side at the benefit advisor level?
Yeah, so we'll work with the provider to understand the culture of the organization. And part of our onboarding of a client is really helping our advocates understand the culture of that organization. And we're moving more and more to that. It's really important that when you're dealing with a machine shop that is 80% men, that your communication vehicles or your targets are different than if you're dealing with a bank where you have 60 to 70% women who are the tellers and administrating the business. So hitting the employee where they're going to engage with that material makes sense. So we work with the broker consultant to really understand that, and then understand what vehicles have worked for that employer. Like I said, some cultures, if the CEO says, we're all going to jump off the cliff, they do. I've had Sargento Cheese as a client for a number of years, And if Lou Gentine said that, they would go. And it is a great culture, just a wonderful company. And I've got other companies where the culture isn't there for many reasons. Sometimes you've got a distributed workforce where you've got two people in an office and you've got 200 offices across the United States. It's a very different thing where everyone does their own thing, and you really have to say, how do we reach those people?
So you've got to meet them where they are.
You got to meet them where they are and really support the HR team. Now, HR managers today are asked to do so many, many things, and they're being asked to do or take on more liability or at least responsibility for the cost of the healthcare. And so they really rely on the broker consultants to identify where the opportunities are, whether it's in the PBM or in specialty pharmacy or in guiding people to value or guiding people to quality. And then once that strategy is determined, like who are we going to target? So if I've got a large client, and one of our clients, we've got over 10,000 employees. So their focus may be very different than that 150 employee company. And targeting the right people can really drive the savings. So we can do that through data, and we can do that through benefit plan design.
Do you have any long-term stats on how, if you get your programs engaged properly, if all the carrots are all lined up and they're all the same size? I have a one-track mind. I stay on analogies. I can't help it. What might that do for the bottom line of a plan?
Well, I can tell you that when we look at this, we're trying to provide an honest assessment of savings. Because if you look at some of the programs, I'm a big fan of Al Lewis, and one of the things that he beats on a lot of times are wellness programs. And as a former CEO, we put a wellness program in my company with 300 employees, and it was a great program. And we had a lot of fun with it, and I think it really helped people focus on healthcare. I don't think we saved any money on it, but that's not why we did it. We did it to get people engaged in their health, and it's amazing to watch people drop 100 or 150 pounds when they engage with the program. But when we talk about things like this, we really want to focus on what can we do on the individual level to really get people to turn the needle. And if we can identify, for example, infusion patients, and that's a big opportunity right now,
Sure.
where you go to facility A, and I think Ocrevus is one we looked at, where it's $85,000 an infusion, where if you go to an independent infusion center with a white bag strategy, it's $45,000. So you don't need too many of those to really move the needle. So for the way we look at this and the way we assess savings, David, is we know what the average cost of a claim for a procedure was for that employer over the last couple of years. Typically, and we get that through historical claims. So I can say, I've looked at your last 50 colonoscopies and your average price was $4,800. And I know that we have high value options where your average price will be $2,400. Thus, you're going to save about $2,400 per colonoscopy. Now that's on average. So, and the employers will say, well, yeah, but how do I know that my employees aren't using the high value places now? And I say, it's all about market share. What market share do you think those high value places have today? And most of them, if they're honest, will say, well, 5-10%, which is true, because these independents, and there's fewer and fewer of them competing against bigger and bigger health systems, they're not going to have more than 10% share. So let's just rule that out, that your people are going to the higher value place, because typically they're not. So we'll know what the average price is, and then I just set that as the example, and that's an average price. So in western Wisconsin, where we sit with a couple of health systems that are very expensive, where a colonoscopy, for example, on an average cost is over $6,000 for a screening colonoscopy. Whereas less than 50 miles away in Minneapolis, the average cost of a screening colonoscopy is about $2,000, and maybe less, but that's the average cost. I can tell you at the high end, we see those colonoscopy costs as high as $18,000, and I'm not exaggerating. So when I use an average price, I'm using the average price in that market. That's a reasonable average price. I'm not taking it from the most expensive, but I am using it from the average price of the high value options that we have. So I can set that up to say, I know that we moved 10 colonoscopies that had we not moved them, you would have paid $6,600. Instead, you paid $2,400, and that savings is your net savings. And then to make it even fairer for the employer, so I'm not over exaggerating what our savings are or their ROI, we net that against the $200, $300, or $500 cash incentive they will pay the patient or the employee for going to that high value place.
We've got a couple of minutes left. I wonder, what are you looking at in the future? What are you seeing in the near term and the midterm for improvements in overall advice to patients and utilization of data in ways that we can get patients activated to go in the right directions?
Yeah, I think the key here is communicating with the employers to really help them identify those black swans that are going to happen. And their better broker consultants know that these 150 life companies that 5 years ago may never see a $50,000 infused drug, they're going to see one. And so you have to write that into your plan design or protect somehow, whether through your specialty pharmacy or through a steerage program or infusion program that works. I think the other thing is really to work within the network to identify those high quality and high value places and really work to get people to go there. And you had asked a question about what are we seeing for bottom line. I want to answer that. And I think we're typically seeing we can save between 3 and 8% of the cost of their healthcare. Some of our top groups are having engagement north of 50%. Our average is about 22 to 24%, and a low engagement group is anywhere from 8 to 12%. So the higher the engagement, the more savings.
And that makes perfect sense. And perfect sense is a great place to end our conversation for today. Ross Bjella, founder and CEO at Alithias. Ross, thanks so much for sharing your information with us.
Yeah, thanks, David. I appreciate it.
I want to give a quick shout out to our sponsor and our producer, Hatcher Media. Hey, if you need podcast production or professional graphic design, Josh Hatcher's the expert to contact. For more information, visit him at hatchermedia.net. That's HATCHER media.net.
This ShiftShapers podcast is copyrighted content and may not be reproduced in whole or in part without the express written permission of ShiftShapers Solutions, LLC. Copyright 2024.